again to try to summarize in the next minutes what we have learned about what has been called channelopathies, and not only Brugada, but I think that it's important that I'm sorry if I might overlap with some other presentations, but I think this is something that we cannot avoid today. And also, I would like to say that this presentation is a presentation that is prepared in terms to summarize what we know about channelopathies, but basically to simplify it. Some of you might think probably this is too simple, but I think that this is a good way of transferring this information to clinicians and to people that might not be such a huge specialist in the field, and that probably we have to do this type of simplification just to make it comprehensible. So you know that sudden cardiac death occurs basically and mostly in the Occidental world because of ischemic heart disease that produces myocardial infarction, produces as an acute injury. One of the consequences can be ventricular fibrillation and sudden death. Also, in the chronic phase of the myocardial infarction, the presence of circuits in the damaged myocardium will be responsible for ventricular arrhythmia, ventricular tachycardias that can lead to sudden death. Dilated cardiomyopathy is one of the leading causes also sudden death. 50% of the people with heart failure will die suddenly, and also other diseases like hypertrophic cardiomyopathy, first cause of death in young people less than 40 years of age, and arrhythmogenic right ventricular dysplasia. All of them are causes of sudden death related to structural heart disease. And this is not the issue that we want to talk today, but we want to talk about what's happening with these people. Some 20 years ago, 25 years ago, we were struggling with the fact that around 30%, 25% of the people that were dying suddenly, we could not find any reason for dying. So we were looking at these people and we're seeing that these people was having a normal heart, but still they were dying. At the time we called that idiopathic ventricular fibrillation. And let's say a nice way to say, I don't know why the hell this guy has died, basically. But okay, and then because we were looking at all these idiopathic ventricular fibrillation patients, we were trying to understand a little bit more about them. And I think that over these 25 years we have learned a lot. We are still left with 7-8% of people that we do not understand. I'm sure we will understand it in the future, but we could narrow this number down quite a lot. And this is why what I will try to summarize now is, as I told you, the idiopathic ventricular fibrillation. We didn't know exactly what it's called. Okay, let's simplify things, because what has happened is that we have learned that a lot of these people is dying because of what has been called channelopathies, so diseases of the electrical channels of the heart, the majority of them genetically determined. So if you look at the channel, and again, this is an oversimplification to make it very easy, the channel opens because there is a massive entry of the sodium into the cell, and this massive entry produces the depolarization of the cell, and phase 0 and 1 of the action potential, and then at phase 1, when still sodium is getting in, the potassium starts getting out and produces the repolarization of the cell. So it is a much slower phase to go back to what we call the resting potential. Okay, so the depolarization coincides with the activation of the heart, QRS complex. The repolarization coincides with the QT interval, which is the time it takes to go back to normal and be able to be activated again. Sodium is getting into the cell, potassium is getting out of the cell to go back to the equilibrium. Simple. Now, what's happening if we have mutations in the sodium channel? Well, if we have mutations in the sodium channel, you can have two elements. You can have what we call the long QT syndrome type 3, and you can have Brugada syndrome. First thing is that we already understand that mutations in the same channel can produce different diseases. That's the first thing we have to understand. So one channel does not mean one disease, but one mutation can produce one disease, because it will depend on what is the effect on this mutation on the function of the channel. And an effect of a mutation on the channel can be completely different depending on the mutation. So you can have completely different, even sometimes contradictory diseases because of mutations in the same channel. Now let's see, this is the sodium channel. Okay, sodium channel is a cylinder, so this continues here, and through this cylinder the sodium gets into the cell. And these are all the software and hardware that makes that this channel works. Opens, closes, let the sodium go in, get some drugs, etc., etc. Now, if you have mutations in all these elements, these mutations mean that the channel has a defect. The protein, remember that the channel is a protein, so this protein will have a defect, and this defect might produce dysfunction of the channel. Might. There will be a lot of mutations that will not have any effect on the channel, because they are mutations in irrelevant pieces of the channel. But others will produce a tremendous effect on the function of the channel, and this is going to produce different diseases. You have Brugada, long QT conduction system diseases, or even combinations of these diseases. Now, what is long QT? Well, we know long QT is diagnosed because the patient has syncopes or ventricular or even sudden death, and the diagnosis is done because you have a prolonged QT interval on the electrocardiogram. You have a clear case of a long QT, a long QT C40, QT C584, very long QT interval. Look at that, a very normal T wave, but it comes very, very, very far after the QRS complex. This is typical for long QT type 3. Okay, when you look at this electrocardiogram and you see a normal shaped T wave that comes very late after the QRS complex, you should immediately suspect a long QT type 3 due to mutations in the sodium channel. Why a mutation in the sodium channel can produce a long QT? We'll see it in a minute, but let's just show that this is genetically determined. This is a family with long QT type 3 that has been dramatic for this family, because in black you have all the people that is dead in this family. And you see that here there is only one live person with a long QT, and that has not had sudden death. All other people with long QT in the family are dead. Okay, so dramatic outcome in this family of this type of mutation. Now, what is happening leading to a mutation in the sodium channel that will finally produce a long QT and sudden death in this family? Well, we have said that we are dealing with the sodium channel. Remember, we are in the sodium channel. The sodium channel that produced the mutation, or the mutation in the sodium channel that produced long QT, does not affect the entry of the sodium. The sodium gets into the cell normally. So the depolarization phase, thus the QRS complex, is normal. There is nothing wrong with that. But the channel should close. And the mutation is producing that the channel remains open. This is what happens. So the channel remains open, and when it should not continue to get sodium into the cell, because the potassium starts to get out, it turns out that the potassium effectively starts to get out, but has to compete with sodium that is still letting in. So the result is that it will take longer to go back to normal, because it has to compensate the sodium that it gets getting into the cell. And this prolongation in the duration of the action potential is translated in a prolongation in the duration of the QT interval. Here you have the explanation for that. This is a sodium channel. Normal sodium channel opens very fast, closes very rapidly, and closes completely. Here is a sodium channel with a mutation, opens very fast, no changes in that, but does not close completely, remains open. And because it remains open, it keeps getting sodium into the cell. It prolongs the time it takes to go back to normal. It prolongs QT interval. Okay. Now, Brugada syndrome. We have said that the mutation in Brugada syndrome can also produce this disease. So, syncope or sudden death, patient with normal heart, and again, a characteristic ECG now showing right with the right block ST1 elevation in V1 to V3, not prolonged QT interval. Now, you have the classical ECG Brugada syndrome with the ST segment elevation in each V1, V2, and V3, prolonged PR interval right with the right lobe. We have seen already this electrocardiogram, and we have seen that this can finally produce ventricular arrhythmias, ventricular fibrillation, and sudden death. Now, you have seen also this information. Again, this is genetically determined disease, so this is a family history. There are many people in the same family that can have the disease, and this is produced by mutations in the sodium channel. Why a mutation in the sodium channel can now produce a completely different effect? Not a prolonged QT interval, but the nasty segment elevation in which we want to eat. Well, again, sodium channel entry, we are already, or we are still in the sodium channel. The sodium channel sodium channel opens and the sodium gets into the cell very rapidly and massively, so depolarization phase is normal. The phase 0 is normal and QRS complex is normal. Now what's happening is that the channel has exactly the opposite effect of the one we have seen for long QT. For long QT we have said it remains open. Now we say it closes earlier. And because it closes earlier in phase 1 of the action potential, where sodium channel should still be open, is already closed. And because it's already closed, ITO, which is the last channel I will name here, ITO, which is the starting channel of the whole repolarization effect, ITO starts to put away some potassium from the cell. This is like the trigger that will start the whole repolarization process. It turns out that ITO has nothing to compete with because sodium is not getting into the cell. Thus, we have an early start of the repolarization, so this might fit with the early repolarization and all these things that we were discussing, and this early start produces an imbalance in phase 1 of the action potential between the entry and the exit of the ions. This produces some imbalance in the currents in different parts of the heart. Why? Because ITO is basically present at the epicardium of the right ventricular outflow. That's why we are seeing basically the elements of the ECG in V1 and V2. So we have this ST segment elevation in this list with a normal duration of the action potential, because at the end the repolarization process will take the same time. Here you have the proof. This is again the sodium channel, opens and closes very rapidly, and here you have the sodium channel at a certain temperature. Remember, I was explaining this morning that, or in the previous talk, that the mutation is temperature dependent. If you warm up the preparation, you see that the channel closes earlier, some milliseconds earlier than it should, and this is this change in the closure of the channel that produces all this imbalance in phase 1 of the action potential. Okay, let's go to the potassium channel. What happens in the potassium channel? Well, we had at least two syndromes, the long QT syndrome again, 1 and 2, and the short QT syndrome. Okay, this is a potassium channel. Again, this is a cylinder that connects this and this. All these are mutations of the potassium channel. And let's see, long QT exactly the same that we have said for the long QT type 3. Syncope, sudden death due to ventricular arrhythmias, and the diagnosis is because a prolonged QT interval in the electrocardiogram. So this is no difference for that. The only difference is that the electrocardiogram in the long QT 1 and 2 do not show this normal T wave that comes very late, but it shows a very broad-based T wave or a very difficult to measure T wave. So completely different aspect of the repolarization. And we have to look when we see this very broad, and we have seen one example with Dr. Aziz before, with a very broad T wave, the first patient he has shown, that was probably type 1 or type 2 long QT, because it's this aspect of the T wave that sometimes you don't know where to measure it, where it finished, and you know that it's a long QT 1 or 2. The final result, again, is Brugada point, so this is not changing, independently of the type of mutation you have. Now, why now a mutation in the potassium channel will produce the same effect as a mutation in the sodium channel? Well, let's see why. So now we are not talking about sudden. Sudden gets regularly and normally into the cell, phase 0, phase 1. There is no difference there. So the the QRS complex is normal. However, the potassium that should start eliminating positive ions from the cell, it goes slowly because the mutation is producing that some of the channels are not working or are not working adequately, and they are slower in eliminating the potassium from the cell. If they are slower, it will take longer to go back to the resting potential. Thus, you prolong the action potential duration, you prolong the QT interval. So you arrive to the same final consequence by completely different mechanisms. Now it's because the potassium is too slow. And the result is the same. Here you have the example. This is a normal potassium channel. This is a potassium channel with a mutation. It's not working. So at least half of the channels are not working because of the mutation, and then this produces a slowing of the whole process and prolongation of the QT. Short-QT syndrome. Well, short-QT syndrome is the last one of the channelopathies that has been described. We described it in the year 2000, it has been said, and we described it with these 3 patients. This patient here was a lady that was a very unfortunate case because this lady had a syncopal episode on Friday afternoon. Friday for us is the day before holidays. Before the weekend, okay, but for us it's Sunday, the holiday day. But Saturday we do not use to work. So on Friday afternoon, this lady, 27, 28-year-old lady, had a syncopal episode in a peripheral hospital, 100 kilometers from our hospital. And the physician that saw her did this electrocardiogram and sent it to me. And then said, what do you think? I said, I think you have a wrong machine, so you should do it again with another machine because the QT interval is 240. This cannot be. So there is a mistake here somewhere, and you should repeat. So he repeated the ECG with another machine, and he sent me back there. It's exactly the same. And I said, well, then we have the short QT. We were looking for short QT. So because this kind of analysis I'm doing with you, we have been doing it theoretically on the blackboard many times with the people and say, it must be something called short QT, and nobody has yet discovered. But it's impossible that with all the mutations we do not have a mutation in the potassium channel that produces an hyperaction of the potassium channel and finally produces a short QT. So we were theoretically already in our head described the short QT. Then I realized that I was probably in front of the first short QT of my life. Unfortunately, as I said, because it was on a Friday and this lady had a very young boy, neonate, she didn't want to come to the hospital for further analysis, and she said that she will come on Monday. Unfortunately, on Sunday morning she died suddenly. So we were probably then sure that we were in front of our first QT. So then other 2 patients were identified, and we could then publish these papers. Now, after this, some families appear, very few. We have been discussing that very few families are detected so far, very few patients, but we could see many patients with, some patients with short QT. We could do the genetic analysis and we could confirm what we were suspecting. That the mutation in the potassium channel producing a gain of function of the potassium channel was accelerating the whole process of repolarization, so shortening the duration of the action potential, shortening the QT hit. And this is the proof for that. So this is the potassium channel, normal potassium channel, this is the potassium channel with the mutation where you have a much higher effect on the potassium, so a gain of function producing the shortening of the QT. It has been also said that we knew that already, but we were not paying too much attention. Some kangaroos die suddenly. You have always seen, there are some of these films where a kangaroo is there boxing and then suddenly he dies. We have all seen that as a child. And they die suddenly. Not because they are hit, simply because they die suddenly. And this sudden death, these are ECGs of kangaroos. Okay, here you have 6 kangaroos. And you see that the kangaroo has a very short QT interval. You see this aspect of very short QT interval. Okay? So probably is a live model of short QT syndrome in the country. So now, then we have learned that other people that has a normal basal ECG might also have some, not channelopathies, but the trafficking of the calcium into the cell that can be affected, and this trafficking of the calcium into the cell can produce finally the polymorphic familial ventricular tachycardia. This is probably the one that we all, the people that are treating patients with sudden death and syncope, we all remember, because we all have somebody that has died because we didn't thought on the disease at the right time. Because we all have had some child that has come to us, who have visited him, who have been watching us their syncopes in the past, and well, we are not completely sure whether he has something or not. Okay, we'll see, we'll not see, we might implant a loop recorder, etc., and then the child dies. And we did not do the right test in them on the right time, which could be a stress test or isopaternal test. Now, of course, this is known, and this does not happen anymore, but in the beginning of all this history, when we didn't know that this was happening, all of us have some patient that unfortunately died because we never thought on the possibility of having this disease. And now, and this is something you should always remember. You have a child with syncopes, and the syncopes are produced by stress, by mental stress, basically. When they go to they are at school, they have to give something, they have to give a lecture, they have to go in front of the parents to make a recitation or whatever, and they have a syncope. Think always on this possibility. And it's very simple to identify if you do the stress test or isoproterenol, and it's relatively simple to treat with beta blockers. Okay, so think on that, because this is something that might, if not be terrible, if you have what happens with the stress test, as long as you increase the stress, you see that more and more arrhythmias occur. And of course, it is because the ryanodine receptors produce an accumulation in calcium into the cell with the increase of the adrenergic tone. And of course then, and this is the last thing, it has been described very recently, the early repolarization. We have been looking at that together with Brugada in the previous presentation. We know that this can be, or can explain again, at this case, can explain again some of the cases we are seeing of idiopathic ventricular fibrillation, so the narrowing of the number of patients that are left undiagnosed or misdiagnosed is getting shorter and shorter. So I think this was my last slide. So, no, it cannot be my last slide. Must be one slide. Okay, here you have more examples of early repolarization. So the final would be that all these diseases, whatever it is, short QT, long QT, early repolarization, at the end produce polymorphic ventricular arrhythmias that ultimately produce sudden cardiac death. So we have been learning a lot on that. So the genetic studies have identified a new category of disease responsible for syncope and sudden death in patients without demonstrable structural heart disease. We call that channelopathies. The good news are that in the vast majority of patients, just looking at the ECG, you must identify the majority of patients that might be at risk of having these diseases and of suffering sudden death. So please look very carefully at the ECG, because we keep learning a lot from a very simple tool, which is the ECG. We thought that we knew everything about it, but still there is a lot to know, a lot to understand, and a lot to discover. Thank you very much.